What if the flexible kid everyone praises is actually the one being missed? In this episode, we sit down with Dr. Sarah Cohen Solomon, a pediatric specialist in hypermobile EDS, who's not just treating these complex conditions, she's lived them. From years of being dismissed and misdiagnosed to now helping kids get answers earlier, she's bringing a perspective most doctors simply can't. We're diving into what hypermobility really is and what it isn't. The early signs parents and providers often overlook, the surprising connection to endometriosis, and what it actually takes to support kids living with chronic pain. If you've ever been told it's just growing pains or it's all in your head, this conversation will change the way you see everything. So stick around. Welcome to Endo Battery, where I share my journey with endometriosis and chronic illness while learning and growing along the way. This podcast is not a substitute for medical advice, but a supportive space to provide community and valuable information so you never have to face this journey alone. We embrace a range of perspectives that may not always align with our own, believing that open dialogue helps us grow and gain new tools. Join me as I share stories of strength, resilience, and hope, from personal experiences to expert insights. I'm your host, Alana, and this is Endo Battery, charging our lives when endometriosis drains us. Welcome back to Endo Battery. Grab your cup of coffee or your cup of tea and join me at the table. Today, I am joined by my guest, Dr. Sarah Cohen Solomon, a board-certified pediatrician and specialist in hypermobile Ehlers-Danlos syndrome and related conditions, including POTS, MCAS, and dysautonomia. But what makes her perspective especially powerful is that she's not just a physician, she's also a patient. After years of navigating chronic pain, misdiagnoses, and medical gaslighting herself, Dr. Cohen Solomon now combines clinical expertise with lived experience to deliver truly whole person care. Her work is reshaping how we understand and treat complex, often overlooked conditions, especially in kids who are too often dismissed. Please help me in welcoming Dr. Sarah Cohen Solomon to the table. Thank you so much, Dr. Cohen Solomon, for sitting down with me today. This is such a fascinating conversation that we're going to have, and I am honored that you have sat down with me today. Thank you.
Thank you. I'm really excited. This is an important topic that gets overlooked very frequently, so I'm excited too.
Yeah. So before we get started, as per our usual, what is your drink order of the day? What is your comfort drink?
I am in a peppermint tea mode these days. It's just comfy to drink all day. I just recently moved. I'm in surround myself with comfy things mode.
Yeah. And it's also really good if you're nauseous half the time.
Yeah, I think I got into the habit that way. I'll put a little tea in, or I'll put a little honey in and make it a bit of a treat. But it works. It works with the comfort. It works with the nausea for sure.
Absolutely. I am still in my plain old coffee era where I just love coffee, but I will tell you that coffee tastes better when it's in your favorite mug.
I agree. I think someone needs to study this. There's no question.
There's no question. Like this is my mug of choice. And if you can't see, it has what's called an Indian paintbrush. It's a pottery.
Oh, it's beautiful.
And so I am from Wyoming, and this is the state flower. And my sister-in-law got that for me. And that's
so
my
nice.
favorite mug, and it always tastes better in there. So no matter what I drink, it always tastes better. So I'm excited for this conversation for a couple of reasons. And it's because I've talked a lot about EDS, and I've talked a lot about endometriosis. There's obviously a correlation there, but what we haven't really touched on as much is just the adolescents that have to kind of navigate this. And as a parent with two young children, this is something that I'm very passionate about because I do what I do because of them. So I think you are the perfect person to bring this conversation to the table. Can you give us a background on what you do and a little bit of your story so we have a good place to start?
Absolutely. So my journey was very fate driven. So I myself have hypermobile Ehlers-Danlos syndrome. I was diagnosed when I was in college, but my symptoms started when I was around 10. And 10 years is not unusual for hunting down this kind of diagnosis, unfortunately. But pelvic pain and pain with menstruation was very much part of my early years as well. So if we're talking about endometriosis, that's really relevant to my pain journey. So I grew up with a lot of diagnosis and medical stuff happening all around me, and really wasn't sure if medical school was gonna work physically. So my whole life involved a lot of trudging through the process of accommodations and accessibility and things like that for very invisible symptoms. So that became very much part of my personhood, not in a it's going to define me way so much as I'm a person who sees where problems still exist, and I'm someone who is driven to fix them when I encounter those problems. So I got to medical school, and that continued to be something that was very relevant to my medical training journey. And in terms of becoming an hEDS specialist, that was kind of an accident. I was actually always planning on at least involving adolescents in my practice. I love teenagers. I love that transition period. And my intention was always to be in academic medicine. But what happened was that my husband and I were out of the country for a few years for his postdoc, and I couldn't work there easily. So I was going up and back to my previous position where I became an Ehlers-Danlos specialist, or a hypermobile one specifically, because that clinic was entirely focused on hypermobile Ehlers-Danlos syndrome and the conditions, as I say online, the conditions that go along for the ride.
Absolutely.
And I wasn't unhappy with that. It was just more of this unusual position will work with my unusual situation. And I know I can do it because I've lived it. So it's sort of the universe telling me, all right, you got to hold on to this identity piece, even though, there's always that debate when you're growing up with a chronic illness. Do I want this to be my identity, or do I want to do other things? But that's how I landed here. And now I'm headed back to the world of academics so that I can also teach this to other people, so that it's not just a small group forever and ever able to diagnose and properly manage these conditions. Because that, I think, is the thing that's most important to me at this point, for sure.
Absolutely. One of the things that I've talked about before is that I was actually going into school to be pre-med, and I realized a lot of my health issues kind of prevented me from doing it fully. And so I switched from that to communications, which oddly enough, I'm now kind of
Now you're
combining
kind
the
of
two,
both. Yeah.
which is why I love what I do. The challenge in that, and something that you spoke about, is just the challenge of knowing if you can accomplish your dreams based off of how your body may be functioning at that time. And that's something that's so real for so many people with both EDS and endometriosis. And that's, for those people who maybe are not familiar with hypermobile EDS, can you just give us a quick synopsis of what it is and maybe some of the misconceptions surrounding it?
Absolutely. So first of all, I want to be very clear that Ehlers-Danlos syndrome actually refers to a collection of conditions. Depending who you ask, it's either 13 or 14 discrete types of connective tissue disorders. 13 of those have a gene that we can actually test on genetic testing, a little cheek swab. And they cause connective tissue disorders that have various symptoms that are identifiable and have clinical criteria to do the diagnosis with that gene test. The hypermobile type of Ehlers-Danlos syndrome makes up maybe 80 to 90% of the total people with a type of EDS, but it's the only type that does not have a gene that we have 100% with certainty identified that we can do a test on. So the diagnosis relies on a really good history and exam and listening to your patient. But what it does is that your connective tissue, which is the glue that holds you together, isn't formed properly, or maybe it's broken down improperly. We're still figuring out the details of the pathology. But what it means for us practically is that our joints are both hypermobile, which means they go too far, as well as unstable, which means they are easily injured or dislocated with the kind of injuries you wouldn't expect. I have dislocated my shoulder by sneezing, for example. That's not normal, obviously. But the more and more we learn about, especially the hypermobile type, and I want to be clear that while I do see other types, I do see majority hypermobile. So if I say EDS, I usually mean that, but I really shouldn't. It's a bad habit. It should be individualized by type. But the more we learn about the condition, and all of them, is the more we see that it is so systemic that we had no idea. When I was diagnosed, it was considered joints only. And now we know that it affects the gut, it affects the nervous system, it affects the pelvic organs. And so it's really important to understand the systemic nature of this connective tissue problem so that we can properly not just understand it, but reach better management planning. Because if we just assume it's one system and one system only, we are really limiting ourselves.
Yeah. I think one of the questions I get often is there a treatment for hypermobile EDS?
That's a great question. So I prefer to use the word management approach. Treatment implies that I've got a magic pill or a wand or something that is going to fix the problem. And unfortunately, right now, the gene editing technology that exists is not ready for human use on this condition. Maybe someday, I think it's possible. The more we learn, the closer we get. But in this day and age, management is where it's at. So I can't fix the underlying problem, but I can make it significantly better, both by early recognition, wink, wink to our pediatricians out there,
Right.
and really understanding how it works. So physical therapy is very, very important, but it's important when it's done correctly. So we don't want somebody who assumes that we're one isolated joint injury that you push through. That's really dangerous to someone whose entire body is involved, because usually there's like a pattern of injury. It's not just, oh, I've hurt my shoulder. My shoulder hurts because I've been walking funny because 3 years ago I sprained an ankle that never healed properly. So I've been hiking up that backpack so I can walk off the ankle. Like that is normal for us. So insurance makes it all about the shoulder, and that means we don't get appropriate care.
Mm-hmm.
So when we look at it as a systemic issue, we get better physical therapy, we get better outcomes, and it's important to be with someone willing to not just learn about that, but take it seriously. So physical therapy, 100% valuable. There are other techniques as well, like Jeannie DeBon has a phenomenal app and membership program called the Zebra Club. She's I believe, Pilates trained instructor out of the UK who works very closely with the Ehlers-Danlos Society. And programs like hers very much focus on getting in touch with your body again, so that the years and years of pain and genuine fear that your body is going to malfunction on you, which is a real phenomenon, you can kind of start unlearning that, because that's an added layer that makes it hard or near impossible to do the work. Because it's not just, I got to exercise. It's, I have to move my body in a way that is safe, but I also have to believe that it's safe. So it's
Right.
It's a whole thing. If I had 12 hours, I wouldn't be done explaining it. But Jeannie's program, the Zebra Club, is great. There are other techniques out there that I'm happy to go into in great detail. But slow start, gentle movements, incorporating it into your day is where I always start. And body awareness. Because, by the way, proprioception, meaning my awareness of where my body is in space, is really poor in people with Ehlers-Danlos syndrome. All types, but specifically the hypermobile type. Like, I walk into doors all the time. I will wake up with a bruise that I don't know where it came from, and that has implications. So it's really important to train your body to know where it is.
Absolutely. I mean, that's something that I've really, really struggled with, is just that spatial awareness of knowing where I am in space. And I work with my trainer a lot with this. And I think that's one of the things that has been really impactful for me, is finding a trainer who does functional movement. What does functional movement mean? It means various things, but what it means is someone who's not going to shove you into doing burpees that you cannot do.
Yes.
It means allowing your body to function at its optimal without hurting it.
Yes.
And that's something that we've had to work on. It could be like a light little touch for me that just helps me know my space better. It doesn't necessarily mean that I can't do things. I just have to modify a little bit.
Exactly. And I love exactly the way you said that. So because I am seeing young people who are growing into themselves and figuring out who they are, the last thing I want to do, and I never feel like I even do this perfectly, but my goal is always to make sure that they know that I'm not saying, oh God, you can't do anything, protect your body at all costs. I'm saying we might need to modify what you do. What I want to do is figure out a way that you can do the things that are meaningful and that you love. Is that necessarily the best thing directly for your joints? Well, if you love track and field and you're slamming on your joints all day, I'm going to have to tell you that might cause harm. But at the same time, not every single person with hypermobile Ehlers-Danlos and hypermobile spectrum disorder, by the way, as well, tagged onto that, is different.
Right.
It's different. My twin sister and I have the same list of diagnoses, and at no point in our lives have we looked identical or been able to function identically at all. So I never want to tell a patient, you cannot do that. You can never do that. I want to say, at this time, that might be dangerous. Let's see what we can do to make it more feasible. And sometimes I need hard conversations where, something is like when the neck is involved, for example, there might be a hard stop. But the goal is always, let's get you as functional as possible. It might be slower than it would be, looking at your friends at school, but I want to do as much as we can to make you as okay as you can. And I want to put a little plug here that does not mean that you can't or shouldn't be using something for mobility. So if you are someone who is also in pain all day, having an easier time moving might mean that you need a scooter or a wheelchair or a rollator or something like that. And that is still better than the pain of pushing through inappropriately and then causing harm. So I'm full team accessibility, mobility aid, and not limiting how we think of movement and exercise. That is only a limitation, and we should not.
There's so much there because, first of all, you and a twin, that should be a case study in and of itself, right? Like,
well, so actually we've been in studies.
Have you? It's like I'm like, this is fascinating.
So the Milner study that came out in 2016 about mast cell activation syndrome, where they found the first triplication gene called hereditary alpha tryptosemia. We were both in that study. She has the duplication. She has that gene problem. I do not. Her mast cell symptoms have always been more severe than mine. We're fraternal, by the way, for the record, so that makes more sense. But yeah, no, you're right. Having a twin with all the things has been scientifically interesting, but also really valuable for the support of it. I never had that pit of despair that comes with feeling like you are alone as a teenager in a battle against your body. I had a buddy automatically. Yeah. And that's not 100% positive, but it was definitely a weird silver lining. So
you're not doing it alone, so you don't feel like the outsider looking in type of thing. Like,
great, we both have it.
Yeah. I didn't even know hypermobility was a thing. Like, we talk about this all the time in the hypermobile space where it's like, it seems like a really good party trick, and it's just really not a great party trick.
Right.
When you get older, you get in your 40s and you're like, yeah, I'm not sure I want it.
The more you do the party trick, the more lax that area can become. So it's easier and easier to injure. And does that cause a problem in everyone? No, not necessarily. But people will come into my office and since very, very often they've been dismissed or not believed by other physicians, they'll come in and be really eager to show me and tell me and convince me that this is an issue. And so they'll come in doing all sorts of, as you call it, party tricks. And I will not be demonstrating for that reason. But, coming in being like, look what I can do. I swear it's real. And I'm like, I promise, I believe you, but put your joints back in and we'll go one by one.
That is a real thing that
I do not want anyone leaving more injured than they came in.
Yeah. Please just don't show me. You can tell me.
Yep. I will believe you. Yeah.
Yeah, exactly. With people with hypermobility, should we use caution, especially because I remember back when I was growing up, I was using a chiropractor to feel better because I thought everything was popping out of joint. I was going to massages all the time. Is there a warning that we should adhere to when these modalities come into play?
I am so glad you asked. So the major thing, really the only thing that I put a complete, please don't ever do this, is a rapid high velocity neck adjustment. And generally speaking, that is a technique that more chiropractors use rather than physicians or physical therapists, but certainly anybody who does manual therapy techniques might do this. So what that means is a rapid cracking of the cervical spine of the neck here. And because there are very important blood vessels that are adjacent to those joints that are being manipulated, if it's done too quickly or without appropriate caution and care, it can genuinely cause a rupture in the vessel, which is obviously very, very dangerous and potentially deadly. So we do not want that. I have had patient family members for whom that has happened to. So this is a real problem. So that's the only thing that I say absolutely never, ever, ever, ever do. Now, to answer your question more broadly, manual techniques are and by that I mean techniques that can allow a joint that's gotten either jammed or partially dislocated or fully dislocated to get back into alignment. And by the way, it's actually sometimes really hard to tell what's partially dislocated versus more of a muscle spasm that is making things feel stuck. And at the end of the day, the techniques who you go to get it fixed are going to be pretty similar, but it's just useful to know that, there are injuries that can feel like that, but technically aren't. And it's words that people use a lot
Right.
to describe what they're experiencing. So chiropractors, physical therapists, osteopathic physicians, so a DO rather than an MD, they've had the same training as me, in addition to the hands-on techniques to work with this alignment and help the body function better, move better. That can be extremely important so long as they are aware of the increased possibility of injury and risk to the vessels specifically. Now, the World Health Organization has a warning saying people with EDS in general, hypermobile EDS specifically, should not go see a chiropractor, but it's really for the reason of that vascular risk in the neck.
Okay.
So what I say is a little bit more nuanced. I'm very shades of gray. What I say is what you want is someone who understands your body. You want someone who is willing to listen to you, understands how the instability of this condition works and what risks that involves, and then who is willing to listen, learn, and adapt accordingly. So if you live in a community that has exactly one chiropractor and no other physician or PT for 100 miles, then what we want is to work very closely with the chiropractor to carefully explain what is safe and what is not safe so that you are getting some care, getting better than nothing care. Depends on the person, obviously, but I never want someone to say they can only see one type of person because that limits who's available. And if I'm being totally honest, a lot of the time, the people who sit in my heart and my memory as care team members who made the most difference for me, they did not come into that relationship knowing anything about hypermobile Ehlers-Danlos syndrome or dysautonomia or any of those things. They came in curious and humble and willing to go home and say, I do not know anything about these conditions. I'm going to go learn about them. That creates a safe bubble where you can create a relationship and be safe and get care and get healthier, even though someone didn't come in with that originally. So I never want to limit that opportunity.
Right.
Yeah.
That's like something that I was always fearful of after I learned that I was hypermobile. I was like, that's one thing I have to be so cautious of. But there were also moments where I needed extra support
Right.
that they could offer. And I think limiting our support system can in some ways hinder healing and relief.
Yeah, I agree. I think that one of the most important things becomes relearning how to trust your body to move and function. And again, that still might include accessibility, mobility aids, etc. But if we walk through life afraid of everything, your body will incorporate that. And so, by the way, that's sensible. That's logical. If a joint falls out with no nothing to cause it, it just does that. Like that is genuinely terrifying. And so it just takes so much effort to feel comfortable and confident again in a body that is inherently unreliable. But that's really the key to a good life. It doesn't mean it erases everything. It doesn't mean we ignore the problem. It means we incorporate it into how we live and how we adapt and how we look forward so that life can be okay. And it's different for everyone. It just has to be.
Yeah, absolutely. I mean, everyone is so different. And that's why our bodies are just so uniquely made to each of us, right?
I love that.
We're so uniquely made. And there's no one size fits all for anyone, right?
But that's often how
where
we're trained in medicine and in most things. And that's not inherently bad, but it is limiting if you're looking at a condition like ours. So it's important that's why I'm going back into academic medicine, because it's so important to make sure that the culture of all or nothing, black and white thinking, multiple choice test taking, that is not what presents to you in the office ever.
Yeah.
Ever.
Yeah. And speaking of office, you work with adolescents.
Yes.
Pediatrics.
Love it.
And which is so cool. Like, I don't often get to talk to someone that's working in pediatrics, but I think I need to more because it's to recognize signs and symptoms and ways that we can support our kids earlier, I think is going to change the difference in the narrative long term for these people growing up. And so
I agree.
With hypermobility and EDS, what are some early signs in children that parents or pediatricians might miss?
That is such a good question. So one of my long-term goals is actually to create some guidelines on this specifically, and early recognition becoming part of, for example, the wellness exam for kids as they grow up. That's just a long-term dream. But for now, first and foremost, if a parent comes in worried, you believe the parent. Let's just start there for a second. You don't come in and say, I got to calm down this parent. You go in and you say, this parent is worried. Let me figure out why. Let me figure out how worried I should be based on how worried the parent is. That's where you start 100% of the time. Now, once you've done that, one of the earliest signs that I hear about is not always necessarily what actually comes into the office. It's more of a let me look back at it. It's that they don't seem to be keeping up with their peers in playtime and activities and things like that. So that early sense of fatigue, the my kid needs to rest more after activities, my kid has growing pains is a phrase that I feel triggered by. And I don't mean that flippantly, frankly.
Right.
But the phrase is overused. When kids come in with pain that is lasting more than 3 months and it is disrupting quality of life or activities, that is a problem and you need to investigate. So pain should always be evaluated. It should always be evaluated. Fatigue on top of the pain should be evaluated. And hypermobile EDS and HSD are not the only things that could be happening there as well, by the way. So we do have appropriate workup guidelines for when someone comes in with what might be considered growing pains and needs to be ruled out for other things. God forbid, one could have in the leg bones. That is one of the top things we worry about when we hear about growing pains for a kid. So this is a significant finding. Don't get all scared if you're listening to this at home. It's not usually that. I'm just thinking as a pediatrician who needs to make sure I don't miss scary things. So yeah, so pain and fatigue is the number one thing. Difficulty keeping up with activities might also be more of the orthostatic intolerance, for example. There's very limited data on that in kids under 12, hopefully more soon. But I absolutely see kids just not able to stand in, say, choir practice or soccer practice. Actually, when they're moving around, it tends to be better during the activity and then they crash after the activity. But standing for choir practice or during religious services, for example, that's when the kid's like, I gotta lean on something.
Yeah.
Or if your kid is, if you go to the checkout line at the grocery store and your habit is to send the kid to the chair that's by the door so that they're not standing on line with you, that's significant too. A kid should not have to go sit down that frequently. So those are the things that tend to come up first. GI issues, absolutely early. Mostly constipation, but can be diarrhea, can be IBS, can be just difficulty with nausea and eating. I anticipate that there will be more and more data on food sensitivities and things of that coming up, but it's still a very vague cloud of symptoms, but GI interference for sure. And then we get to adolescence and we hit menstruation and hormones. And if someone comes in and does not have pain with their periods, I'm actually more shocked.
Yeah. So much to be said about that. So much to be said about that.
Yes.
Which we'll get into.
And just to be clear, again, to anyone listening, painful periods does not mean go get a workup for hypermobile Ehlers-Danlos syndrome, but it does mean that pain with periods should be taken seriously. Your child should not have regular pain with their periods that disrupts their life. There are things we can do about it. Do not let that think that that is a normal situation or something that should be put up with. Just
100%.
saying that loud and clear.
Yeah, I agree. Also, for me, I had a lot of bruising, just random bruising.
Yes.
All the time. All the time bruising. And feeling just dizzy, or those are things that I often felt as a kid, which were really unexplained to me.
Absolutely.
I didn't know why.
Those are very, very common symptoms for sure. One of the issues with those is that they can get very much lost in the picture. So a gripe I have with our board questions, for example, this 100% true. I had a board question during medical school, what's called step 1 of the board exams, that said, a teenager comes in with a lot of bruising, and I think it was like a joint injury, like a shoulder dislocation, and then it said also the parents are in the circus. And then they had a picture of the thumb hypermobility. What condition might this individual have? And I was like, wow, that's weirdly specific of you, board exam question creators. Thank you. But it was just like, none of my patients come in first mentioning the bruising. It's more like, once we kind of understand things, the bruising becomes a little bit more clear, or there's apparent worry that there's a blood disorder causing bruising, and then they mention it earlier. Because it's prevalent. I bruise like a peach.
Same. For long times. They stay forever.
They do. And that has to do with poor connective tissue. So there's poor healing, even though it's not the same risk as the vascular type of Ehlers-Danlos or some of the other specific types, CV, EDS. There's still a general vulnerability to our vessels more than the general population. Details TBD. But healing is slow. Easy to bruise, slow to heal. It is what it is. Now, I do want to make a really important point that is very serious, which is that in children, excess bruising can be looked at as a potential sign of abuse. So it's really important in that setting to document what's happening.
Yeah.
because God forbid that becomes, a medical concern, because we as pediatricians have a responsibility. We are legally bound to, and ethically, morally bound to, make sure that a kid in our care is not being harmed. So if we have a concern for abuse, we have to report that. There's simply no other option. However, very few pediatricians, just in terms of our training nationwide, are deeply familiar with EDS in all of its forms. So we also have a responsibility to be informed and aware of conditions that might make it look like abuse. So we know, if a kid has osteogenesis imperfecta, for example, or OI, which is also called brittle bone disease, and there are a couple different types of that, but the colloquial name for it says it right there. The bones are brittle. They break easily. You're going to see that on a physical exam and on the history. If you get an x-ray, you can see various, stages of healing. So pediatricians who specialize in abuse know to look for that, for example. But usually that's already diagnosed. Hypermobile Ehlers-Danlos, not so much. And there's debate about whether bone fragility is involved in hEDS. There is, just to be clear, there is actually no strong, well-done study or data to support that bone fragility is a clear symptom, but there is also not 100% data to suggest that it isn't. We're in a gray area. But bruising is definitely something that happens with HSD and hEDS, as well as the other types. So,
Yeah.
and that's a very serious, very important subject.
I mean, and we've talked about flexibility, right? Like, it's not just about flexibility with
Correct.
hypermobility or EDS. When should flexibility raise a flag for young?
Pain and injury. Yeah. So flexibility, I love that you asked this. So these terms are used so interchangeably online, and I'm guilty of it as well. So flexibility has more to do with the muscles being toned and trained to be able to do things like gymnastics and ballet. But flexibility also implies that it's a muscle skill where you have some control over it, where you are stretching to be flexible. That's not a bad thing. Hypermobility usually is inborn, although, if someone is very flexible, you can kind of push and maybe look like you're same as hypermobile. But technically, hypermobility means the ability of the joint to go further than the average distance. So you can be hypermobile in one area. You can be hypermobile in several areas, and we have categories for that. But what's really, really important is that hypermobility all by itself is not a problem.
Right. Okay.
It's not. If you have hypermobility with appropriate flexibility and strength, go be a gymnast or a ballet dancer. Please continue appropriate care with sports medicine anyways, but you might not ever have a problem other than the fact that you are doing sports. However, instability, because the connective tissue isn't doing its job well, is where the problem becomes a problem. And so you can have hypermobility without instability and have no issues in your entire life. There was a kid young adult, I went to medical school with, who had the most flexible and hypermobile elbows that I have ever seen in my life. And he could do push-ups, he could do pull-ups, he was fine. He'd never had an injury. It was just everyone in his family had the same thing. They went, when I say they went far, they went far. And it was his genuine party trick. No injury, no problems.
Huh.
And that was always my good example of, like, you can have flexibility, you can have hypermobility. If it's not associated with instability, it's not really a problem. But we use all those words very interchangeably. So instability is where we start getting the chronic pain, the injuries that don't make sense, large and small. And that is where it becomes a problem. That is where it becomes a problem. Yeah. So even things like, I would say younger kids are going to have your frequent ankle rolls. Mm-hmm. Walking along the street and suddenly, boom, you've got another sprained ankle, and it's like, oh yeah, no, we've done this before. We've got another one. All right, because it becomes very normalized within the family. Or I have several families who went to the ER so many times for something called nursemaid's elbow, which is a very easy dislocation to have, especially when you're young. It's actually so common that we adjusted criteria in 2023 to not overdiagnose, because it's super, super, super common in young kids. Because if you have your kid and you're holding them by the wrists to do something silly like swing them around, boom, it comes right out in young children without EDS. But if it happens frequently enough that you're in the ER and the ER staff is like, maybe I'll just teach you how to do it so you don't have to come in, that is a signal that I need to hear about. If you know how to fix that yourself, something is wrong.
Never put that together. And now I'm like looking back at, like, even my kids, and I'm like, gosh, you know, like, this is so important to pay attention to those like minute details. To some are huge details to providers who can address this.
And I
Like,
want to be clear, it's about the pattern. It's not one thing.
yeah,
It's never one
yeah,
thing. So,
right.
you could have a parent who that elbow just got dislocated so many times they wanted to save time, but nothing else ever happens. The kid has no other symptom, lives a wonderful life, da da da. Or it could be part of a picture.
Right. Absolutely. What are the risks of not recognizing this early and recognizing EDS or hypermobility
Yeah.
spectrum disorder early?
That's a great question. And it's very difficult because the data we have is really based on inadequate care and inadequate recognition. So I am extrapolating when I talk about these things. So the younger kids I see, mostly, not 100%, not as severely affected yet. I do have a handful who are very young and very severely affected. And for those, I'm also very considerate of doing the full genetic panel to make sure I'm not looking at something else, even outside of the EDS spectrum. But the younger kids usually are more like clumsy, if you will. Sorry, guys.
Yeah.
They're having a hard time keeping up. They might have pain. They absolutely might have pain, but they are not already necessarily out of school as much. They are not, every organ system involved as much. Constipation, yes, but, they might not yet have the headaches or the period pains, da da da. So what I like to do with the younger kids is get them into PT that focuses again on that proprioception, body awareness, learning how to listen to your body. I don't like calling it setting limits so much as body awareness. And my hope is that by doing those things early, we are people love the phrase like resetting the nervous system, but kind of, yeah, if we can do a reset when you're young, you might walk into things less. So you might have fewer injuries. You might be more aware of, oops, I've made an injury happen here. I fell down. My ankle is going to be a problem. Let me fix that before it becomes a cascade of issues into everything else. So you have a toolbox in place already so that you can function better and not have to kind of dig yourself out of that physical hole of symptoms. Because the older you get, the more I see that there's this, it's a hole, it's a backlog of, all right, I can't eat, I can't sleep, my head hurts all the time, I can't focus in school, the school is mad at me because I'm never in school. And it's just, it's everything always, all of the time. Because it affects everything always, all of the time. So that's what I see the older they get. Not everyone's the same. It's not identical. Sometimes the symptoms are kind of manageable until adulthood. For some people, pregnancy is a trigger for symptoms getting more severe or significant. Sometimes there's an injury that's like really severe, a surgery, something like that, and it can kind of tip the scales towards worsening situation. But yeah, the earlier we can increase at least awareness, if not some management and intervention, I think the earlier the better. Hopefully the data will follow. Yeah. Did that answer your question?
For that sometimes. It takes a while. No, it's excellent. I feel like there's, as a parent with a child that potentially has hypermobility of some spectrum. It's something that I'm so aware of because of my own history, right? Like we as parents oftentimes put ourselves, and maybe wrongfully, in our child's shoes, and this like, did I go through this? Are they experiencing the same things? And also that can help them get care much sooner because we are becoming more educated and more aware of the things that have affected us. And I think we're starting to talk about these things more. And that's why I think, understanding what we should be made aware of is key to knowing where we should go in our journey and in our care
I agree.
for our kids.
Yeah.
And how do we advocate for our kids if we don't know what we are advocating for sometimes, right?
That's such a good question. Yeah.
Yeah. What are we advocating for sometimes, right?
Let me ask her. So humor aside, I think that's one of the biggest challenges for parents. And I'm not yet a parent, but have very strong memories of my mom with her tote bag with all of the medical records. And I will never be able to thank her enough for the advocacy for both my sister and myself. Never.
Yeah.
If she hadn't fought, we wouldn't have gotten our diagnosis. So, that's people sort of assume that I'm doing this mostly for catharsis for myself. It's actually more for my mom. It's more because the burden of caretaking and unraveling the situation falls so heavily on the parents.
Yes.
that I saw what she took on and had to take on, and I don't want anyone else to have to do that. So in terms of how and what and when, again, going back to what I said earlier, if a parent comes in concerned, you take that seriously. So how and what should the parents be doing? That's a great question. If we're working with somebody who has a diagnosis for themselves as a parent, that in and of itself is just a reason to be watching carefully, because there is an inheritance pattern, even if we don't have a gene to identify. So
Right.
keep it in mind. We take a family history for a reason. End of story right there. The parent is still figuring it out or has not been diagnosed themselves. And often because it runs in families, there is some limitation on recognition, because it's like, oh yeah, the whole family just gets tired after an outing, or, oh yes, the whole family gets joint pain after whatever, it's okay. So there's a normalization by accident that limits recognition. It's nobody's fault, but it is a funny pattern. And there's very often, if I'm doing the workup for a teenager, there's usually a parent in the corner being like, oh, it's me. So I'm the problem. So there is that. But how to do the advocacy? Oh man, oh man, oh man. So first and foremost, your child is your first priority, is my understanding. So I will never say to someone that what they're doing is too much. Obviously, there are lines not to cross. Please don't yell at my staff. But if you feel that you're not getting the care and recognition that your child requires to be healthy and safe, you keep going. And there's danger in that. Culturally, the phrase doctor shopping really needs to be abolished, because to me, there's this fine line of, all right, this horrible phrase of doctor shopping is meant to imply that a family, an individual is looking for an answer. They're looking for a diagnosis because they're trouble in some fashion, and they're never satisfied with what they're getting. No. Turn that phrase around and say, my child or myself, we are not finding the answers and we are suffering. Should I not keep going to more doctors to try to find the answers? So we've got language that needs adjusting. That's a systemic problem, and unfortunately the burden falls disproportionately on the families. But generally what I tell people to do is write down your priority questions. What is disrupting the quality of life most, so that we can prioritize what needs to be looked at. Because even if it's not HSD or hEDS, I have the privilege of being able to figure out other things too. So we need to know what is most problematic for you, what's most bothersome. I generally recommend against going into an office setting, unless it's with me. By all means, do it with me. And saying, I saw online that my kid feels these symptoms and I want you, the doctor, to evaluate for this condition. We don't really like that. We're not trained for that also. We're trained in the other direction. So when we're trained in medical school, we're given a script for how to do a patient interaction. And it begins with, what are you here for? What is your chief complaint? I hate that phrase also, because it means everything is a complaint. I have a lot of issues with the language we use in medicine. So a person comes in, they say, this is what's bothering me, and then you dig into the symptoms as a detective. And then you, the physician, make a list of what you think is most likely. You do an exam, labs, whatever is appropriate, and you make, again, a list of what's now most appropriate, and then you treat accordingly. The world we have now means that everybody comes in, and this is not an inherently bad thing, but people come in having done their research. And the phrase, I've done my own research, is a great way to trigger a pediatrician. Again, I don't use that phrase flippantly, because the internet can be good or bad. It depends what you use it for. So if you come in and tell a physician that you've done your own research, I promise you they will go, because it means most of the time, it gives the physician the signal that you have something in your head that you're going to leave unhappy unless you get that specific thing. But it might not be medically the most appropriate thing. Now, I have been the patient on the other side of that conversation, and I got to tell you, when physicians respond that way, it's very unhelpful. So these conversations are really sticky and really difficult, because the internet can be magnificent. It's amazing, the data and the information we have access to. And I got to tell you, most of the time my patients come in correct.
Right.
They do the research, they look things up, and they're correct. So, but anyways, if you come in and tell the physician, this is what I want done, that's almost always going to not go well, just because of what we're trained for, the worry about doing inappropriate medical testing. So what I recommend instead, if you're really concerned about a specific diagnosis like hEDS, go in and say, these are the symptoms that are most problematic. They are causing these issues with quality of life. Also, because I want to do my due diligence for my child, I've been reading as much as I can, and I try to stick with things that are reliable, because everyone's going to assume you've gotten your information off of TikTok, which sometimes is good, but not always. And you can come in with, journal articles. Don't overwhelm the physician. We only have finite period of time and say, look, I have this concern. I know it might be other things, but I'd like to give this thought so that at least I can be reassured.
Yeah.
So a little bit of humility on the parent side so that it doesn't feel to the physician, you're about to be in trouble with the patient if you don't do exactly as I ask, like a hostage situation. We don't want that.
Right.
But because of how often patients come to me having seen, 20, 30, 40 doctors, that's common. They come in with trauma, genuine trauma.
Yes.
So it's really hard to have those conversations gently and advocate for your child gently once that's all built up. By all means, come see me and tell me all about those things, because it's actually valuable information for me. So I know where you've already been, what has been ruled out, and what the workup has looked like.
Right.
But that's me. I'm set up for that specifically, and I'm asking for it, So it's hard. This is one of the hardest things I think a parent can ever do.
Absolutely. And as a parent who has walked into doctors' offices and had discussions on this, one of the things that I always walk in with, and this is kind of just how I have phrased it, is it worth considering X, Y, and Z based off of these symptoms?
Yes. And then follow up with, and why not? If they say no, why not? And not to be pushy, but to say something like, thank you for considering it. Can you explain to me why not, for reassurance? And then you can say, can you document that so I can remember and pass it on to the next doctor so that we can rule things out and not reinvent the wheel every 10 minutes? Right. What you said right there is beautiful.
Yeah. And I, as a patient who has experienced medical trauma, I have to kind of as a parent, I have to be able to drop my trauma at the door, because it's not about me in that circumstance. It is about my kid. However, I will tell you that as a parent, sometimes we do experience medical trauma in efforts to help our children, right?
Undeniably.
So we experience that with our kids. And I do think that it's worth considering getting someone to help you walk through that, because and you can probably speak to this a little bit better than I can, but if we don't walk through that and work through some of that healing process, it then goes on to our kids. And the trust factor diminishes even with our kids at an early age, because that is how they're being taught to approach medical care. And not saying that all medical care is this way, but I do think that we have to be very aware. Like, if we're going and seeking help, there is a chance we might have medical trauma come from that. But also, can we walk through this in a safer way? And is there a way that we can address those traumas that then don't create more of a generational trauma? And so that's something that I'm very aware of with my kids, because I do have that, and I have to be very aware not to pass that on to my kids.
That's so insightful. And again, I say that this has got to be one of the hardest parts about parenting when you have a kid who has a chronic illness. And I know that my mother would agree. And so one of the things my mom says all the time about self-care and about being the person helping the other person as either a caretaker or a medical professional is that if a boat has a leak in it, you can't help the people in the boat if you're in the boat also. And by that, she means, that it's important to put a priority on helping yourself, at least at the same time, if not first. Airplanes, put your own air mask on, then help your kid. You can't help your kid if you don't have your own oxygen. And that, I think there's no parent alive who'd be like, oh yeah, that's my instinct. Let me help myself first. That's not how that brain part works, right? So you're right. Addressing and respectfully managing one's own trauma is key, because I absolutely have parents who it's very clear sitting in the room. They are holding it right here, and they are scared, and it is valid, and it does make it harder for them and the kid and for me. Not blaming, just truth. And so something that's valuable there is being able to teach your child the language for self-advocacy because of one's own experience, for example. But I have seen it swing too far where kids who are very, very young are incorrectly using medical terminology because it might have been appropriate for the parent's condition, but it's not technically appropriate for the kid's condition at that time. But that's the language that's been passed down. So caution needs to be, part of the picture. But that also means you have to have a physician, a medical team that's there to help you. And it's not only the burden on the parent to do all of this. It's not fair. So I want to emphasize that there's 100% a role for appropriate mental health and therapy. And by appropriate, I mean, we are not going to make the condition go away by going to therapy. That is not how we use therapy. That's not an appropriate referral. Please.
I can clap to that all day long. That is where a lot of medical trauma happens, is when they just refer you to
Uh-huh.
mental health.
Yes. So, the clinic that we're building, like, we know this is important. But what's also important is that if you live your life in fear of pain and in pain, you're going to need some therapy at some point. It is not fair to you as a human being to not have someone helping you with that burden. It's hard. It is hard to independently get your brain on track if that is what you're dealing with.
Mm.
Those are facts. And so there are people who are trained with trauma-informed care and pain management understanding to understand how these types of chronic illnesses affect you as a human being, so that you can at least remove the layer of mental and emotional anguish that adds to the physical.
Yeah.
Because why do we need the extra layer? We don't need get rid of it. I don't want it. Let me just deal with the glue that isn't working properly. I want the emotional stuff dealt with separately, And to not do that, I feel, is a disservice both to the kid and the parent. But you got to say that right, and you got to say it at the right time, because you're absolutely right. If that's what's offered instead of all of the other, I've got so many medicines, I got tips, I got tricks, I got all the things, but if I only offer you therapy, it's inappropriate.
Right.
It's inappropriate.
100%.
Yeah, it's negligent, frankly. I'm going to get
I would agree.
canceled for
And
that,
that's
but
where,
it's negligent.
a lot of us look back at our own history, and this is what we're going to, kind of go into, is that with my endometriosis diagnosis, that medical history, like, to be told you're crazy for your pelvic pain, for all the other pains that you're experiencing, and that just be kind of like, it felt like a scapegoat. It felt like it being invalidated for our symptoms. And that's something that, like, so many of us have experienced. You were talking about the prevalence of pelvic pain in EDS patients, or hypermobile patients. There's now some emerging research backing up the, conditions that like to party together,
Yes.
those EDS,
Going along for the
endometriosis
ride, as I like
patients
to say. Yep.
coming along for the ride.
Yep.
And they were not welcomed to this show,
They
but
were not invited. They crashed.
they crashed it. That's right. And that's why, like, I have talked about this before, but there's a high prevalence of endometriosis patients who are also hypermobile or have EDS. And there's now some research to kind of back that up. Can you talk about this a little bit?
I'd love to. I'd love to. So it's just so exciting to be a physician in this field in this moment of exploding research, because 20 years ago when I was diagnosed, there was just nothing, just absolutely nothing.
Right.
So first of all, I think it was about a month ago now, maybe a couple more, there was a specific paper that was put out technically it included all types of EDS. So the data has a little bit of limitations because of how it was collected. It was by ICD code, or diagnosis code. And so we can't be 100% sure how to generalize or be specific, but that's fine, because it was big enough numbers that it's still valuable. And what that showed us is that people who have any type, but certainly probably generalizable to the hEDS specifically, 7 times the risk of having endometriosis as the general population. Holy moly, good grief, that's 7 times, So,
Right.
and then there was another paper. Actually, there were several papers out recently from the Norris lab at Medical University of South Carolina that focuses on Ehlers-Danlos conditions. And they were looking in this paper at the whole spectrum of symptoms that are reported in HSD and hEDS specifically, so not generalizable. And they found that in hEDS patients, pelvic pain was present in 80%, and in HSD, it was 66%. And that's too many percent to ignore.
Significant.
Yes, that's terrible. And there was a whole slew of additional symptoms in both papers having to do with gynecologic and menstrual related symptoms that are hard to live with. Things having to do with pain during sex, pain that comes with your period, if your period is regular, or if you're someone who's having a period very frequently, inappropriately frequently, was on the list too. This is a huge life problem for a not insignificant part of the population. If we are all agreeing that HSD and hEDS is actually maybe 1 in 500, maybe closer to 1 in 250, that's enormous. Those numbers are big. I'm not going to do that math.
No. And the prevalence of endometriosis, they say 1 in 10, but likely they're looking at 1 in 7. And if you correlate that with the percentage of hEDS, EDS, like I got to assume it's got to be, there's got to be some crossover there.
It is worth looking into based on those numbers. Let's put it that way. It is absolutely worth looking into. And the more we look into it, the more we find, forgive the pun, connections.
Right.
But, it's hard to get big numbers because if we historically consider these things rare or not happening much, or we don't record it adequately, then where do you get your numbers? So that is always a limitation in research, unfortunately. We're getting better at it. That's the silver lining. This is huge. Yeah. But you were mentioning, the not being believed aspect. I think there is nothing you can do to harm a young person growing up more than not believe them.
Yes, 100%.
Yeah, because not only are you telling them that we're not going to help you because of your, I don't believe your symptoms, so I'm not going to give you care to make your life better. You're also telling them that you shouldn't trust your own sense of self. You shouldn't expect safety in the medical realm. You shouldn't expect to have your needs met, and you shouldn't believe yourself when that is happening. And if you start being told that when you are a small person, that's horrific. That is how we end up with systemic problems like doctors taking advantage of patients and things like that, because a patient doesn't learn to say when something is a problem because they've been taught not to.
And it's interesting to think about that, because I'm sitting here thinking about like when I was potty training, right? We tell our kids, listen to your bodies. Well, if you go in and you've trained your kids to listen to their bodies, how does it feel inside? Do you know, like when they're feeling sick, what do you feel? We're training this from a very, very early age. If they're going into a provider's office in a place where they should be able to trust the outcome, and they're being told they're not, what they're listening to isn't valid, it has to have deep repercussions for that.
Yeah, there's no question.
Like, long-term repercussions for that. So, and we've said this within the endometriosis space for so many years, is part of the healing process, part of feeling like we are being heard is being validated, right? Even if you don't know what the sign or what the symptom is, you can say, I believe that you are feeling this way. I just don't know what it is yet.
Absolutely. There is so much power in that sentence. And I'll add as well that, especially for, the younger it starts, if you tell a person that their symptoms aren't real and that it's not happening, they still need to live their life. So by the time they get to my office, they're often very not sure of not only what symptoms they're experiencing, because there's sort of a fight or flight situation. Your brain is over here and your body experiences are over there, and they're kind of separate. So the parents are often in there with their notes saying, okay, well, my kid gets home from school every day expressing pain and da-da-da, but the kid's like, I don't remember. I've put it in a box over there so that I can make it through my day. But then they also come in and I will ask things like, all right, tell me about, your pain or whatever. And they'll say, I have the normal amount.
Right.
You should not have any pain. You are 12. If you have pain, I want to know about it. And they're like, pain's not normal? Well, you've never lived in another body. You've never lived in another body. How on earth are you supposed to make a distinction between normal and not normal unless there's been a change in your body? Sure. But if your body's always had a connective tissue disorder that does this, why on earth would you recognize what's not normal? I have kids who get on my table all the time, and I will notice that like a shoulder is dislocated and they just consider it normal because it's been out for I don't even know how long. And then I'll put it back and they'll say, this is how I'm supposed to feel? And then they can move comfortably and some of their fatigue is relieved and things like that. And they are in genuine shock. I cannot tell you how often the first thing, this always gets me, the first thing out of my patient's mouth when I say, oh, yes, you definitely have this condition is, you mean I'm not crazy?
Yeah.
Teenagers. You mean I'm not crazy? For that to be the first thing that you say when you have a diagnosis that you were pretty sure of, you came in thinking this is the thing you have. That's why you're in my office. And then the first thing you say is, you mean I'm not crazy?
Yeah. I mean, that's,
ouch.
It's mind blowing. And also we are really good at, that word gaslighting. And I don't love the word all the time, but like, it also means what it means, like, we do gaslight ourselves into thinking that it's not a real symptom. And if we're always doing that from an early age, like we don't know any different, and I even have said that before of like, I don't know what normal feels like, but what is normal? How do we put normal into words? Like, I don't think there is a normal, if we will.
But for me as the physician, if they come in with a concern about how something feels and it relates to how I feel, I can usually be like, not sure that's normal. Let's think about that together.
Right. Yeah, absolutely. As a physician, if someone comes into your office with pelvic pain, should we consider both EDS and endometriosis given the new research that's
Hmm.
come out? Should we always kind of look at both of those as being differential diagnoses? Because
That's a great question. I would not say that the data is substantial enough to say everyone who comes in with pelvic pain should be worked up for hypermobility. But everyone with pelvic pain who has other systemic concerns, other joint pain, that's going to nudge me in that direction for sure. But there's no specific guidelines about that available yet. This is all literally new within the last several months. So we're headed in the right direction. And genuinely, I'm of the opinion that we should be screening people for hypermobility and, well, specifically instability when they're young anyway. So I'm a little biased there. But certainly if they're coming in and they've got the pelvic pain plus many other things. And again, I dislike this phrase, but what we say in medicine is if your review of systems, which is to say you're checking head to toe other body systems to make sure we're not missing anything, if it's called pan positive, so you got the headaches, you got the nausea, you got the diarrhea, the constipation, dizzy, all the things. Every system has something clicked in the chart, pan positive. If you are somebody who has pan positive, we got to connect those dots. Then I'll start screening. 100%.
Interesting. See, and as a patient, I sit here and I'm thinking, I wish someone would have, given my symptoms, taken a whole assessment of head to toe, which is hard to do in a 15-minute appointment the way that our system is built currently, right? Like you have 15 minutes as a doctor to like really get to the crux of what's going on.
Impossible.
Like, you can focus
Absolutely
on one
impossible.
or two symptoms, right? And so that's what makes it really hard, I think, for things like endometriosis and EDS or hEDS, because you're not given the time needed to really fully assess the whole system, right? We are given a silo of a system as opposed to the entire system. And so I think that's what's really challenging, but there are some key things that we can be asking that can maybe differentiate what direction we go. As a patient, how should we walk in when we have concerns of both endometriosis or EDS? What are some main questions that we need to ask when we walk in that door? This conversation doesn't end here. And honestly, part 2 is where we get into some of the things I wish more families were actually being told. We're talking about how to advocate for your child in appointments when something feels off, how to walk in with clarity around your expectations and what you want out of the visit, and what to do when you're not being heard. We also go into the overlap between neurodivergence, endometriosis, and EDS and how that can completely shift the way we understand what kids are experiencing in their bodies. And then we get really practical pain management tools, support strategies, and what it actually looks like to help kids feel more supported day to day. So if you're sitting here thinking, this sounds familiar, or this might be my kid, I really want you to come back for part 2. There's a lot more we're going to unpack.